But let me just quickly introduce Kieran Moore, who's got a very long title. Associate Medical Officer of Health, Program Director of Public Health and Preventative Medicine.
That's probably good.
Is it?
Yeah,
well, let me at least just say then that he's from Queen's University.
Okay, thank you.
Over to you, Kieran.
Well, we're just trying to make up time. So thank you very much for the opportunity to speak with you today. I'm honored to be invited to this conference and to follow Liz and Allison on how we can educate physicians about this emerging infectious disease risk in our population. So I have to thank the organizers again and again and again. I'm different than the previous two speakers. I want to say up front that I don't treat individual patients. My main responsibility is to take care of populations. And as such, I'm going to go through the strategy of how we've tried to educate physicians about the risk of this new emerging infectious disease in our population. So I'm going to describe why it's important in my neck of the woods in southeastern Ontario. I'm going to review some of the core contents of the strategy which we use with our healthcare professionals. I hope you can hear me well at the back. And describe how we're trying to communicate more effectively with our physicians to let them know about this risk. And certainly Liz has raised the point that we sometimes have difficulty penetrating into the clinician marketplace to have our voice heard regarding infectious disease risks. And describe how we need to be persistent and consistent in our approach to educating physicians. There will always be early adopters that will read up and pay attention to what you send them, but then we have to deal with laggards. Like in any profession, there's those that aren't going to read, that aren't going to pay attention to the messaging that you send, and we really have to be, like a marketing firm, very persistent and consistent of how we educate our physicians. Further, I'm a salaried employee of a local public health agency. I receive our funding from the province as well as our municipality. I receive no federal funding. I receive no honoraria. I'm not making any recommendations regarding any products. We have created an action plan on Lyme, which is based on the Public Health Agency Action Plan, and that's what I'm principally going to be talking about today. So, why did you invite me? Well, I happen to work in Kingston, and this is a Public Health Ontario risk map. We have a high rate of Lyme disease in our area, and are part of that whole southeastern Ontario area of risk, starting from Brockville all the way down through Hastings. And this is an epidemic curve of the incident rates of reported Lyme to our local public health agency in Kingston. And just to frame it further, our local public health agency cares for around 200,000 people. That's my family practice. That's the population I'm responsible for. And you can see in 2006, we were receiving a significant number of cases, probably equal, slightly above the Ontario average, but progressively, since 2006, in 10 years, we've had a significant rise in the incidence of Lyme in our area. And we're now at approximately 30 cases per 100,000 people, which would make us equal to the rates that are occurring in endemic areas in the United States. And the key thing is, how can we communicate this effectively to all healthcare workers in our community? That we are now an endemic area, this is not going to go away, and how can we prevent this illness in our population and effectively treat it if patients present to our emergency departments and hospitals? So this is the data that I use to convince family physicians, frontline healthcare workers, that they should be paying attention to Lyme. They should adhere to the messaging on treatment. And as a result of our high incidence rate in our community, we've created an action plan for the last several years. And we try to be transparent and accountable to our community of how we're trying to communicate the risk of Lyme across southeastern Ontario. Our goal is to mitigate the risks to area residents and visitors posed by Lyme disease through activities undertaken in collaboration with key community partners. If you don't remember public health, we collaborate, we communicate, we coordinate across the health system spectrum as well as with community agencies. And we try to do the same with Lyme disease, communicate with our schools, our universities, our colleges, our main employers about the risk as well as with our healthcare system. The main objectives that relate to educating healthcare workers is number 3. Our goal, we stated, is to provide education, resources, and tools to local healthcare providers so they are better equipped to recognize Lyme disease and provide early and accurate diagnosis and treatment. And I think we've heard it again and again and again from patients. We really want to identify this disease at the earliest possible time frame and treat it effectively so that we don't have incidents of chronic Lyme in our area. And that is the message we're trying to get out, is prevent it from happening in the first place, but identifying it early and treating it appropriately early. And in terms of communicating with healthcare workers, well, we try to provide clinical guidelines or let them know about the clinical guidelines. We inform them of the epidemiology of what's going on in our region on an active, continual basis. And we try to provide that information to all of our healthcare workers within our health unit, because we go out into the community and can educate everyone in our community regarding this risk. So get our own house together, but also work with our healthcare workers who are providing online or direct patient care like Liz and Allison about the risks. And so I'm just going to give you a couple examples of the epidemiologic data that we provide to our community and healthcare workers. We're happy to say that we have a real-time surveillance system throughout southeastern Ontario where we monitor every presentation to every emergency department in our region, and we track every visit that's related to ticks. And we present this data in a report every 2 weeks to our healthcare workers to let them know whether tick season has started, whether the risk for Lyme disease, which is associated with tick bites obviously, is also going to be on the rise, just to give them situational awareness that, my goodness, yeah, tick season is back. And we follow that through year by year and compare each year. And this is just people showing up with ticks or tick-related illness. And we also monitor emergency department admissions to hospital, any meningitis, any encephalitis. We follow up and ensure that our neurologists, our infectious disease physicians are considering Lyme disease as a possibility in the differential diagnosis. A huge educational effort across the health system is necessary. And we also show them this was passive tick submission data. So patients bring the ticks to our health unit and we submit them off to Public Health Ontario and the National Medical Laboratory. And you can see since 2009, actually going back further, the tick numbers have increased and the percentage of ticks with the Borrelia in them has increased significantly. So this is a 20% marker here. And once you're above 20% consistently, you're considered in a highly endemic area. So this would be similar to the endemic areas in the United States. So 1 in 5 of the ticks found in our region have the Borrelia in them. And that's a key message we have to get out to our physicians, frontline healthcare workers, and the community, clearly. And that has increased and will probably stay in the 20 to 30 to 40% range as in Lyme, Connecticut. Key real-time information that's essential for decision-making for physicians. We also spatially map and compare what's going on in our region. So the darker the color, the higher the number of tick presentations, the higher number of cases of Lyme disease. And we compare our regions in real time with this type of mapping tools. Some of the key messages, and this is consistent with what Liz and Allison and what many members of the panel have been saying, is that you have to make sure your physicians and your community understand that you're now a high-risk area. And we get that message out through radio, through TV, through press, through ongoing communication as soon as the snow is gone until the snow comes back. And that's our job, to communicate that risk to the public as well as to healthcare workers. They must understand that Lyme disease should be very high up in their differential diagnosis of any rash, of any appearance, that's a new onset, and any undifferentiated fever, chills, muscle aches, and arthralgias in our region. Lyme must be in your differential diagnosis. And some of the key lessons is just how to remove a tick. So we educate physicians following CDC guidelines on tick removal, for example. And we try to educate physicians about the life cycle of the ticks, because they're typically, as Liz and Allison have pointed out, we're not taught this in medical school. This is a new emerging zoonosis that you've seen from our epidemic curves. Physicians aren't aware of how to identify ticks and the risks associated with them. And an engorged tick differential from a non-engorged tick. And Our physicians are trained to look for this expanding, perfect textbook bullseye. And as Liz has pointed out, we have to tell them that the spectrum of rash is from a purple increasing bruise on a lower limb to a cellulitis-looking rash on the trunk to an itchy, pruritic, scaly rash that's expanding anywhere else in the body. The presentations that we've seen or heard reported to us in public health have been so variable that we'd love to create just a photo album of all the rashes that presented to educate the public and the physicians, and perhaps we could do that at a national level. I've seen rashes that have gone to dermatologists, even in our region, for biopsy because the physicians weren't considering Lyme disease. I'm embarrassed when I hear stories like that I haven't educated our physician community enough. But if you start thinking of physicians are transient, in our neck of the woods, we have tons of residents, learners that come from across the country. So this idea of persistent and consistent education of physicians is very important due to the migratory nature of physicians' practices. And we have to educate them about the highest time frame and highest risk period, which is typically when the nymphs come out. And our epidemic curves correlate of true Lyme cases reported to us in public health do correlate well with the nymph, which is very difficult to see, very difficult to identify, and often missed. So we try to educate physicians regarding that as well. And as we've heard today and last night, it's a clinical diagnosis. I don't want my physicians waiting 3 weeks, 4 weeks turnaround time for a blood test and not treating patients appropriately and early. And I can't say this enough to our physicians. Don't wait for the tick results, which could be 3 months. Don't wait for the serology results. This is a clinical disease that should be treated immediately with the appropriate antibiotic regimen. And I'm a public health physician. I don't treat patients individually, so I depend on guidelines to refer patients to. But clearly, physicians can make their independent choices on what antibiotics are prescribed. And we typically do refer them to the IDSA guidelines. And in Ontario, this is a guideline that is used frequently by Ontario physicians supported by the ministry, and it has not a bad chapter on acute treatment of Lyme disease and the appropriate doses for first line, second line, and third line. So it's a one-pager with appropriate references, and we try to ensure that all physicians have access to these types of documents, which are free. At least they are informed of appropriate treatment guidelines. And we try to get across that false negative tests results may occur when testing for Lyme disease, especially if the patient's treated early. And our goal is early treatment. So don't depend on the test for confirmation of your diagnosis. Be confident, if you're in an endemic area like ours, that you should just treat and not worry about the diagnostic testing. I'm not a laboratory expert, I'm not a member of AMI, so we typically refer our patients to Public Health Ontario labs for expert opinion regarding interpretation of more complex testing, because you can get, as we've seen with EIAs and ELISAs and Western blots, difficulty interpreting and putting them in clinical context. So I refer them to medical microbiologists in our region. Excellent information from Liz and Allison again on integrated tick management. We try to educate our physicians so that they can educate the public regarding how to safety-proof your backyard, your cottage, the environment that you're working in, and simple instructions that we have in pamphlets in every physician's office that they can distribute to their patients. We also have pictures on safety proofing. This is from a CDC guideline. We know the ticks don't like the sun and they don't like to be dried out. And this is one prevention strategy that we try to use in our community, both with healthcare workers and the community in general. So pictures on the right is what we want. We don't want high, grassy, non-sun exposed area to protect our children. We also have an algorithm on prophylaxis, which is based, again, I'm not the guideline expert, but based on the Sanford guideline that is sometimes used by our physicians in our area for tick bite. So in terms of how to educate our physicians, we try, as I said, be consistent and persistent. We use electronic messaging We have over 400 healthcare workers. We've got around 600 full-time healthcare workers in our region. 400 have signed up for our newsletter, and we send Lyme updates particularly as soon as the snow's gone, so March and April, and we re-send them out in June and July, which is the peak of the epidemic in our region, and then follow through with a newsletter in November regarding Lyme disease risk. We just try to update them to ensure that we have the right dose penetration into the medical market. And we provide simple one-page sheets on our review of the best evidence, and we try to update this regularly for our physicians. Because, as Liz will point out, busy family docs got a lot on their plate, and we have to make it simple for them to adopt improved knowledge regarding Lyme disease. We try to ensure that they know that this is a reportable disease so that we can count and track and follow up on any clinically diagnosed Lyme cases. And this is very important for epidemiology and for our understanding of how well we're preventing further cases in our region. We also provide a vector report to all of our infectious disease and Emerge colleagues about how many ticks we found this month, whether we've had cases of babesiosis or anaplasmosis, or detected anaplasmosis or babesiosis in any of the ticks. And last year we were able to inform them that we sadly had a case of Powassan encephalitis in our region, and that patient actually died from that tick-borne encephalitis. So we try to keep our physicians up to date and ensure that they're aware of what's circulating. Whatever we get, we share back with the community and with our physicians and as close to real time as we can. I also attend Emerge rounds, family medicine rounds, and present to them to try to keep them appraised of the epidemiology. We also attend any healthcare worker conferences and usually have a booth set up about public health programs. Our infectious disease colleagues, both pediatric and adult, typically present updates on Lyme disease at each conference that they put on an annual basis. I mentioned the Healthy Directions newsletter, our biweekly surveillance reports, and we also use our professional association to get messaging out to physicians because they have good penetration of the medical market as well. And so we've tried to provide basic education on ticks, the associated diseases with ticks, educational material to help them treat Lyme cases, and again, we're available for consultation if they're not aware of what's circulating in our community, and we'll refer them to Public Health Ontario medical microbiologists as needed. We use best evidence for us, which would be Public Health Ontario, which is our scientific advisors to local public health agencies. They've got a decent website on Lyme disease, and they link to the Public Health Agency, CDC, IDSA, Tick Management Handbook, which we're going to be hearing about shortly, and Tick Identification Guide from the CDC. And we try to maintain our own website, but nothing can beat large organizations that have much more scientific power than a small local public health agency. And this study of knowledge, attitude, and beliefs of family docs was done in May of 2012, which Liz identified. Clearly, we haven't done this in Ontario. I think Quebec has done a survey of knowledge, attitude, and beliefs of primary care providers. We should be doing this every year. I have to be assured that my physicians know about this disease, that I'm educating them appropriately, that they can identify the rash, that they know the local epidemiology. And I think both doing surveys of the public and their knowledge, attitude, and beliefs and behavior changes regarding Lyme disease in our region would be important, but also our healthcare workers. So I applaud Bonnie for having done this work, but we have to follow it up with ongoing education of physicians. So, I went a little long. 18, not bad. So I've described why perhaps I was invited. I'm from a high incidence area in southeastern Ontario. I've described some of the strategies that we've been trying to communicate with our healthcare providers and how we do it on a regular basis. Can we be better? Yes, we can. We have to evaluate how effective we are and how persistent and consistent we have to be to improve the knowledge base of all physicians across Ontario, but specifically, I'd love it in our area. So thank you very much.